Ladies and gentlemen, welcome to the Merge Medical Podcast. I'm your host, Dr. Jeff Brown. I'm joined by my co-host, Dr. Jeff Cole and Dr. Geetinder Goyal. Geetu is the CEO of First Primary Care, and I met Geetu through a mutual friend, another mutual physician, and I'm just absolutely so glad he is here. Everything he's doing aligns with the mission of Merge Medical. It's all about patient care, empowering physicians to take their lives back, improve the lives of patients, and enrich us financially. Geetu, thanks for joining us. Why don't you tell us sort of your version of the elevator pitch of First Primary Care?
Thank you both for having me again. I really enjoyed our first meeting at our mutual friend's house, and subsequent conversations, and now to today. Super excited and grateful to be here. So I am an internal medicine and pulmonary critical care physician by training. I finished my fellowship from Yale University in 2013, where I spent obviously 3 years doing pulm critical care. And a lot of, what I do today, I feel like started during those fellowship days. And the start of all this was my frustration with end-of-life care in the ICUs. I felt like we spent so much time dealing with end-of-life issues inside the ICUs, whereas they should have been discussed and handled outside the ICUs in primary care offices with those patients and families, because everybody saw what was coming. And yet, I felt like our system, because it was such a, patient comes and goes and on to the next one, especially at the primary care level, there was no real time to talk about end of life. So in the ICU world, I was getting burnt out, basically feeling like I'm not really doing meaningful work. I'm just trying to unwind a lot of the conversations that should have happened way before. That this is now our health system should be. We shouldn't be spending billions and billions of care in the last 2 months of people's lives, right? We should be really investing way before. So that was kind of the beginning of it. Finished fellowship, didn't really see myself working in the traditional system for the next 30, 40 years of my life, because it felt such a I guess rat race for me, because it was more patients you see, more money you make, kind of idea basically. And I really wanted to do my own business, really wanted to own my own practice, and I wanted to do something big, right? I didn't want to just open a solo practice. So the idea was, if I were to fix healthcare, how do I fix healthcare?
Mm-hmm.
So read a lot of books, but a lot of the answers came down to, we got to start by fixing primary care. That if the primary care continues to be, you're seeing 25 patients in a day, we can never solve primary care. And if we don't solve primary care, you can't really build a healthcare system that has a strong foundation.
Mm-hmm.
So in spite of finishing fellowship, I started a direct primary care clinic.
Mm-hmm.
Direct primary care at that point made a whole lot more sense to me. And the simple analogy again is, we are doing primary care in a blockbuster fashion. You want to go see a doctor, you go in, you go see the doctor, pay the money, come back. And then you got to go back again. So it was a very transactional approach to primary care, whereas the Netflix model, the subscription model, made a whole lot more sense, because it eliminated insurance out of between the primary care doctor and the patient.
Mm-hmm.
It allowed primary care physicians to streamline revenue collections, eliminating a whole swath of administrative burden from billing, collections, all that comes with it, fighting insurance approvals. And it allowed that model, the membership model, to leverage technology to connect with our patients via text, telephones, video calls without having to worry about copays and collections.
Mm-hmm.
It allowed us to have lots smaller panels for our physicians, and we basically were able to put time back into a doctor-patient relationship, right? Um, and that was very well appreciated by the patients as
Sure.
well as the physicians. Physicians started, enjoying medicine again. Nobody was telling them, you got 20 minutes with this patient and you got to move on. They could take their time. They could take 30 minutes, 40 minutes, an hour, sometimes 90 minutes. We could text each other on an ongoing basis. If I want to check in on somebody, I can text them. I can video call them. So it became a continuous care model rather than an episodic care model.
Mm-hmm.
And that made a whole lot more sense. And then we started building transparency on top. What do I mean by that? You get lab work through us, you pay what the cost of the lab is, not the inflated price. And we talk about pricing before we do the test, which doesn't happen in the traditional system because everything is hidden under the insurance copay or
Right.
deductible. We start talking about imaging pricing. We start talking about, surgery pricing. And, we started in 2016, from the garage, like you guys,
Right.
me, a nurse practitioner friend of mine who I had met in the hospital doing some ICU shifts. He was a family nurse practitioner. He had just finished. I pitched this idea to him. So we started, knocking door to door. And it was tough 1 year, trying to convince people, hey, this is the better way. But we then found self-funded employers. Employers were paying a lot of money for health insurance premiums for their employees. They wanted to control costs. They wanted to improve access to care. And what they wanted to do and what we were doing was a really good mesh.
Yeah.
So we found partners that started incorporating us into health plans. And in the last 2 years, we've been pretty much doing our own self-funded health plans for companies, controlling sort of the entire ecosystem on health in the healthcare, but it is all built around the direct primary care model. 65% of the healthcare now happens without any insurance at the DPC level. About 25 to 30% of the care then happens in a guided fashion by the primary care doctors to specialists on a cash-based system. And the last about 10 to 15%, we actually use the insurance network to do it. So it makes healthcare a lot more transparent, a lot more streamlined. The incentives of our physicians are on the side of the patients, and you restore the role of insurance to cover really catastrophic issues and not the day-to-day issues, basically. So that's really what we are doing. Long story, but
no, that's great.
This is amazing, and there's so much to unpack, and I hope we do. But just thinking about you guys starting in 2016 and thinking about the exploding premium rise that we've seen over that course of time, where I think probably did make sense in 2016, but man, it really makes sense right now,
right?
In that premiums have far outstripped any growth in wages, and I think employers are looking for this, patients are looking for this. It just seems like such a better model. I have patients ask me all the time, how much does that brace cost, or how much, and we don't know. It's not that we're trying to play hide and seek. We really don't know, and that's just a problem with the industry itself, the way it works. I'd much rather be able to say, yeah, this is how much it costs, and be able to at least say, yeah, maybe you should go to Walgreens and pick that up. But we don't know if insurance is going to cover, it's not going to cover. And so, yeah.
I'm looking at the first article you pull up, health insurance company profit. First half of 23, 7 big health insurers pulled in $683 billion in revenues. And here we are as physicians. I doubt there's a physician here that we know that's making more money, at least from an inflation adjusted perspective, than they were 7 or 8 years ago.
Yes. And reimbursements have gone down overall, right, from insurers. So it's not like more of that premium that keeps rising is going to the physicians. It's
no.
not.
And this is what I really want to make sure we understand. The costs. So we're paying more as consumers as well. I'm a physician, but I'm also a patient, and my copays go up and my premiums go up, but my access to care goes down. And when I go to the pharmacy to get my prescription, if I have insurance, it costs me more than if I just use GoodRx.
Yes.
So in a very simple way, direct primary care eliminates the administrative costs that the insurers charge to administer, in quotes, administrate the plan. Is that accurate?
Yes, absolutely.
And how much can you tell our viewers approximately, or give us a range, what kind of cost savings do the employers see and the patients see that are paying in their copays and premiums, et cetera?
So if I look at an employer group, about 100 lives, in general, we are able to save them anywhere between $2,000 to $3,000 per employee per year. Right. So in a 100 life company, you are looking at about $200,000 to $300,000 of savings in the health plan.
So it's fair to say a 100-person group is going to save $250,000 a year.
Correct. Correct.
And that is cost across the company, or is that per the employer?
So it translates into both employers and the employees.
I see.
Because the plans we are designing, I think that the other problem with the traditional insurance model is that most of the employers will cost share with the employees.
Yeah,
right?
For
Employer
sure.
will say, hey, I pay 80%, you, Mr. Employee, pay 20%.
Right.
But not just 20%, the employee also has copays, deductibles, co-insurances until they're out-of-pocket max to meet before insurance really covers anything, right?
Right.
So a lot of the burden actually falls on the employees. And that is, in my opinion, a big fundamental problem, because day-to-day care becomes so inconvenient, and there is an obstacle of a copay and a deductible in front of you to get that day-to-day care. When that's delayed, people are, getting sicker. People are going to higher cost facilities. People are going to emergency rooms unnecessarily. There is no continuity of care. So the whole system becomes way more costly for everybody, because you have now put barriers in front of people to just get day-to-day care. So coming back to direct primary care, you eliminate all that by making that primary care model available to employees at no cost.
That's right. And you're incentivized to make them healthy, because you actually have more time the less you see them, but they can see you as much as they want, right?
That's correct.
So we're supposed to be calling this sick care now, but your model can actually be called healthcare, in my opinion.
That is exactly right. My incentive now is to keep my patients, my members, healthy. I am their consultant. I am their advocate. I'm their primary care doctor. And I will partner with you on your healthcare journey. And our goal is to keep you out of trouble. More I keep you out of trouble, less of my time and resources you're going to need. Right? And so my incentive is not to make more money or profit off of sickness. Sickness doesn't pay in our model because our costs are fixed. Just because you use me, 10 times in a particular month because we were trying to solve a particular problem for you, doesn't mean you will pay more than the other guy who didn't text me at all that 1 month.
That's right.
Right. So our incentives are now aligned, and we can truly develop a healthcare model and then design insurance in a way where we cover sick care. But there has to be transparency in the middle. You can't see, simple definition of value is quality over cost. If the cost goes up, value goes down, right? If, let's say, quality is the same, cost keeps going up, and so we keep getting less and less value, basically, right? And until we start having conversation around cost, we don't even know what value we are getting, basically. So I think cost transparency is very important in the kind of the healthcare, sick care system and how we finance the whole thing.
Gitu, in your base layer, you say that the care is free, but there's a membership model. Am I right there? I mean, there's some out of pocket, but it's done through a membership model, and I think very much proven through beyond theory that's costing these employees and these patients less than they would be paying through a traditional plan and deductibles and all that.
So that's correct. Our membership gets baked into the premium. So when you pay the premium, you already have a lot of free care baked into the program, right? So now you are not paying more copays and deductibles to access care. Whereas in the traditional system, you pay the premium and then you still pay your copays. Maybe your once a year annual physical is free. But other than that, for every little thing, you are, paying basically. Whereas in our model, a whole lot of that happens at $0. Lab work, genetic medications, doctor visits, anything we can do in the office, EKGs, breathing treatments, skin tag removals, minor procedures that primary care offices can do, well woman exams, all that stuff happens at no cost to the plan and no cost to the member. If we guide your care to an MRI place where you can go get a $400 MRI, then still the employee gets it at $0 and the plan incurs a claim of $400. Okay? So a lot of care still employees can get at $0 as long as it is guided by their direct primary care that is within the plan.
Can you imagine getting an MRI for $400? I mean, I know people who meet their deductible
just by getting an MRI.
Mm-hmm.
Yes.
Yep, I do.
Yeah.
And so kind of tell me a little bit about that, because when you and I talked a lot offline, and I want our audience to hear, you're not just primary care, but you're also partnering with radiology groups, ASCs, anesthesiology groups, et cetera.
I think, a lot of our specialists are in a similar boat, right? Like, I think a lot of our specialists are also sick of fighting the insurance companies, fighting prior authorizations, and even having to collect deductibles from the patients, verify benefits, how much I need to collect, how much I need to bill the insurance company. It's a lot of overhead that comes with that process, right? Delayed payments. So our proposition to our specialist is, give us your cash price up front. What is a good cash price for you? We want you to be profitable. We don't want you to be, losing money. We want you to be a viable business model, but we want to simplify a lot of the headaches for you. Give quality service at a fair price to our members, and we will make the payment the same day, right? Let's eliminate a lot of the administrative hassle for you. You don't have to collect from the employee. The plan is covering 100%. Again, all we ask is good quality care at a fair price, right? So I think it's a win-win for everybody. The patient, again, gets guided care, deductibles waived. Health plan now is paying a fair cost, not the $4,000 MRI cost. They are paying $400 cost. And our radiology partners are happy because, again, we have simplified their operations significantly in the whole process.
Now, there's one thing I'm not understanding, and I want to make this clarification because if I'm not understanding it, I don't think the viewers will be either. If I'm an employer, some Frito-Lay or whoever, FedEx in Memphis, and I work with First Primary Care, my employees at times will still require hospitalization in an emergency fashion, something beyond what First Primary Care can provide. So they're still using some type of health insurance, such as Blue Cross Blue Shield. Are they then able to just negotiate those plans to be what we would call hospitalization or catastrophic plans for obviously much lower costs?
So, a couple of things here. Number one, you are managing in a 100 life company, let's say 4 or 5 people will end up in a given year in a hospital situation, right?
Mm-hmm.
Our plans, the last 10 to 15% that I had talked about, is specifically made for these kind of situations, right? We embed a PPO network in our plans. You can rent a PPO network and you can embed the PPO network in the plan. So what do I mean by that? For example, in Memphis or in Tennessee, we are using First Health Network. And a lot of physicians that we have already looked up, gastroenterologists, cardiologists, they are part of the First Health Network. So our plan is administered by an independent party. We call it a TPA, third party administrator. But we use that network to access any hospital or specialist in that network. The claim then hits our plan and it is processed according to the network contract, right? So if you are part of our plan, you end up, with a broken tibia fibula, you need emergency hospital surgery. If that hospital is in network with First Health, they will send the claims to our health plan. Our health plan will process that claim according to the First Health network contract between, that hospital and First Health, basically. And generally, these contracts are done on a, multiple of Medicare. Like, we pay 150% of Medicare, 130% of Medicare. So that claim is processed and is taken care of, right? Same thing Blue Cross will do, right? If you have a Blue Cross policy, Blue Cross, you're going to go to an in-network hospital. Hospital is going to send the claim. Blue Cross is going to pay the claim according to the Blue Cross contract with the hospital. But in Blue Cross's case, Blue Cross is the network and Blue Cross is the administrator.
Mm-hmm.
We have separated those two things out. That we can rent a network, but the administrator is our partner. So they're the ones administering or receiving claims, processing claims, and making the payments. And our TPA partners can actually negotiate on the behalf of the patient and the plan with the facilities, and potentially save costs there as well.
And then a couple follow-up points to that. So if I'm an employer and I'm using First Primary Care in Tennessee and my employee travels to Idaho, you don't have a partner in Idaho. What happens in that situation? And then the second question would be, I'm assuming these employers are self-insured, but you have a stopgap insurance behind First Primary Care, correct?
So yes, so absolutely. So first of all, no matter where you travel, you have access to us remotely. You can text us and we still provide care for you. We can still send you prescriptions, manage your care. But you can go to any facility if you need to go to, and we will process those claims again by a percentage of Medicare.
Mm-hmm.
Our TPA will pick up the phone, talk to the facility. Hey, we got your claims. Can we pay you at 130% of Medicare to get the, everything resolved and move on? So it doesn't matter where you are in the country, right? In fact, it doesn't even matter if we have a network or not, because everything is in network. And we can process those claims at a certain percentage of Medicare. So we actually don't play this whole in-network, out-of-network game at all in our health plans, right? The second question is, employers' risk in any self-funded plan is capped.
Mm-hmm.
And they know what their risk is before they sign on the dotted line, when they, start the plan, which is typically a 1-year commitment at the minimum. Right?
Mm-hmm.
Beyond their risk, all health plans have to be insured by a reinsurer.
Mm-hmm.
Reinsurer, or we call it stop loss insurance. And the first step we have to go do when we design any health plan for an employer is actually go to our stop loss partner and get a stop loss quote from them. These plans are underwritten. So we have, underwriters that look at your group, look at estimated healthcare costs, and they will tell you this much claim funding the employer should do. And employer can actually dictate, I want to take, how much risk I want to take. If they want to take more risk, your stop loss premium is lower. If they want to take lower risk and transfer more to the stop loss, then your premium is higher, right?
Right.
But generally, let's say in a 100-employee company, I will have a specific stop loss and an aggregate stop loss. Specific stop loss means for any employee, if my claims go over $25,000, then stop loss is going to pick up all the claims above that.
Right.
And you can also have an aggregate, which could be, let's say, $1 million in a year. Anything over $1 million, then my stop loss policy covers that, right? So my risk is capped. Right? But now you have visibility into the $1 million claims fund you as an employer is putting in, and paying $400 MRIs out of the claims fund versus $4,000 MRIs out of the claims fund makes a huge difference to that claims fund.
Okay, of course, right.
And then you've already gotten paid for basically 65% of the healthcare because direct primary care is already baked into it in a fixed cost. More people use care here, less they go to emergency rooms, hospitals. All that then goes into managing the claim fund. And if there is surplus left over at the end of the year, the employer gets to keep that surplus. Now you got to fund less next year to design the whole plan, right? So it gives employers a lot more control over their healthcare dollars, basically. Otherwise, they're just writing checks more and more every year.
Who are the major players in the stop loss business? Is it those same insurance players, or is this a different crowd of insurers?
No, this is so. Major insurers are actually their own stop loss companies, right? Because they are behemoth insurance companies. They don't need anybody else.
Berkshire Hathaway types.
Yes. Yeah. But you guys seen it in the property and casualty side, other side. There are a lot of insurance companies, right, that run their own captives. And, so similarly, on the healthcare side, also, there is a ton of them out there. I mean, I can. We were just talking to Tokyo Marine. And then there was this underwriter, they are with Manhattan Life, American General. So a lot of big stop loss companies out there who want to do this.
When you're walking me through this, and Jeff, you'll agree, is it not staggering the cost that these companies add to healthcare that gets in the way of you taking care of somebody? It's just mind-boggling, because he and I talked a lot offline, but there's so much money in this that the companies are taking for actually very little. And in his model, the physicians are making more, seeing less patients. The patients are paying less, staying healthier, and the employers are paying less. I mean, it's an absolute no-brainer, right? And I know you've got competitors, I know, because I've heard of direct primary care before, but it sounds like at least you're articulating that you've got a lot more than just a concierge model to primary care, right?
Yeah, I think, generally people understand that if you are operating primary care in a concierge model, you can do a lot better job, right? So a lot of people are taking that route. But you have to, I feel like, fix the insurance problem on top also.
Right.
You can't just say, hey, I do primary care well, I don't know, what to do about the rest.
Right. Still
go pay Blue Cross and figure out a way how to cover that big, bad, ugly stuff.
Right.
I don't think you can do that. I think if you do primary care well, then you are the one who understands the true risk of your members, right? Like true health of your members. And you are actually in the best position to design insurance around that to cover their risk. So why not get involved in that? Why not, redesign insurance and align it, similarly, use it to cover sick care, keep health care out of it, basically, right? And I think we have a beautiful opportunity to do that, and we need to do it as physicians. We need to do it. Like we were talking, that tell me one insurance company that actually healthcare insurance company that physicians own.
I don't know one.
None.
We don't, right?
Yeah, there are malpractice physician mutual companies that
Right.
do a fantastic job.
Yeah, they do a great job.
And they actually, if a mistake was not made, they are not going to settle. I mean, they're going to go to bat for their members and their claimant. So, yeah, there's no doubt that I think this is a flag that physicians would want to fly. I love your vision of what you look like, a few years into the future. And I guess with that, there's a question: are you aware of anybody else that has this vertical type vision?
I don't know in the DPC space. So I think the understanding of what we are doing is absolutely there, right? Like a lot of, smarter than I am physicians there who understand this whole process of deconstructing the health plans and designing it this way, right? But I don't know how many are successfully doing it in the sense that how many have actually found solid stop loss partners, TPA partners, pharmacy benefit manager partners to put the whole stack together, tie it in a bow, and find a distribution channel to get it out there into the public, right? I think people are doing it in components more so than having a full stack that they can fully confidently say, hey, this is how it works, and our health plan is better than yours.
So when it comes to just your margins of business, your cost of goods, your COGS, I mean, can you get where you want to go just with organic growth, or is this something where you'd love to have physician investors and really grow this to a national scale with that type of wallet and movement?
I think the financial model behind the business is pretty solid. If you look at, just the direct primary care model itself, right? If you just look at primary care as a standalone business by itself, even if, on average, you are able to collect about $80 to $100 per member per month, the math works out beautifully with physicians taking care of about 600 patients per panel, right? Organic growth, I see it happening. I see, massive organic growth happening actually at the grassroots level, where physicians are jumping out of their traditional practices and saying enough is enough.
Mm-hmm.
I want to open my own practice, and I want to do it in a membership-based system so I can do justice to my talents, my skills, and justice to my patients, right? There is really a DPC movement that is fueling that growth. However, if you look at the big scheme of things, it's a tiny drop in the bucket. So I think we can scale this a whole lot faster if there is a collaborative push. Both, the intent has to be there that, hey, yes, we're going to fix this healthcare mess.
Mm-hmm.
But you're going to need capital to grow it fast also. You're going to need to have to recruit doctors and then obviously fill their panels. And that does take capital if you want to do it at a faster pace. But I also think there are a lot of other products that should come out of this, right? Products in the sense that if you are starting your own physician health insurance company, that should be a viable business model on its own. And primary care is just a component of that insurance plan. So I think we do need physicians to come together, put some money in to start our own insurance company as well.
How does Stark and anti-kickback and all of these things that are placed against us, how does that play in?
Good question.
Have you looked at that?
In general, even when we do our health plans, right? Like when we do our self-funded health plans, primary care is very separate from insurance that way, right? Insurance doesn't know what's happening in the primary care world because it's again fixed costs. You are taking care of the patients. And then what you are doing is you are giving patients basically access to, hey, you can see whoever you want to go see, but if you go here, your cost is $0 because we know their price up front, right? And then the self-insured funds pay that doctor directly. There is no money exchanged anywhere else, basically, right? Like it's not that they are paying me and then I'm paying, somebody else. So the money flow is directly from the plans to the providers, and there is no collusion there at all.
Hmm.
Now, have I looked at, what in certain states, physicians are, for example, not allowed to own hospitals or own facilities, right?
Mhm.
Because there the concern is, okay, I see patient here and send them to my hospital to do the care, right? I am not in favor of that. I think that is a completely bogus rule.
Yeah, for sure.
So, I think we do need to probably clarify at the insurance level also. If I am the insurer, can I be the service provider of my own insurance company,
Hmm.
right? And those rules may again vary state to state. So something definitely to look into more from insurance standpoint. If physicians start owning their insurance company, can they be providers of the insurance company as well? I believe so. I don't see any way of violating it, but I'll have to, do some diligence.
I got a question. It may be too granular. If it is, we can bypass it. But if you're talking about, we're just averages $100 per patient per month, a 600 patient panel. The providers, are they employees of First Primary Care or are they partners? And tell me about the revenue share, if there is any, or how that works.
So at least in our First Primary Care, everybody is an employee. And generally our goal is that our physician or staff salaries are 45 to 50% of our collection from that care unit, basically. So the way we want to grow this is have a physician leader, have a family nurse practitioner, and have a medical assistant make one care team. And that care team together takes care of about 1,200 members. And, from there, we want to, so for simplification, let's say they take care of 1,000 members. We are collecting $80 per head. That's $80,000 per month collected. Out of that, 40,000, 35 to 40,000 should go to pay our physicians, nurse practitioner, and medical assistant salaries, basically, per month. So I believe physicians can make, $20,000 to $25,000 per month doing primary care very comfortably in our model.
Yeah, and that's not very many patients to see.
The best part, I think, for our physicians is controlling their own schedule. They have, we're not telling them 8 to 5, right? Or work on charts Saturday. That all that disappears. They have life outside work also. If they have a sick kid, they can take the kid to a doctor's and still manage their own schedule. Right? If I have my panel, nobody puts patient on my schedule. Only I can put patients on my schedule because they will text me. I will communicate with them, and then I'll make time to meet them in the clinic when we both can meet. Right. So a lot more flexibility in our model for the physicians.
And how are you marketing this right now?
So we've learned a lot of lessons marketing wise. Couple of things I want to say here is number one, we started obviously marketing this only as a direct primary care, offering, right? We didn't know how to bring, the bigger offering to people. So we were relying on a company's existing broker to take what we have and embed it into their health plan.
Mm-hmm.
And they generally saw it as, you know, an added cost. Because if you're already paying, let's say, $500 premium, and I come to you and say, hey,
Yeah.
pay $80 more, you know, now in a 100-employee company, you know, suddenly the cost has gone up, you know,
Right.
significantly, right? And they're like, how are we going to make that happen? We can't. So that was challenging. And we solved that problem by, again, making it into DPC health plan and not just DPC
Mm-hmm.
offering by itself.
I got it.
We had to do a lot of work to get our stop loss insurers and everybody to reduce their premiums because the DPC was there. So the overall cost of the product was competitive, right? We weren't just an add-on, basically. So that took a while. And now that we are, you know, talking about DPC health plans, it's a lot simpler conversation to have than saying, hey, this component is here and then this component is here. It truly just works as one component, right? Second thing we did was we earlier were of the mindset that the broker community is part of the problem. That broker community, again, because they take 6% of the annual premium as commissions, higher the premiums, better the commissions, right? So who benefits from rising cost of care? All these health brokers do, right? But for them also, the game became unsustainable because employers were desperate. The people who were buying care, they're like, look, I cannot continue to pay 10, 12, 15, 20% increases year after year. You've got to find something better. Broker community started feeling the pressure of, hey, we got to do something more innovative to bring to our employers. We can't just buy off the shelf, book up plans, you know, and sustain this. So, you know, while that was happening, while we were getting better, and then also my mindset changed that let's not fight against the brokers. Let's make them our allies. Let's at least get some of the good ones who truly want to do the right thing and not just take a commission check to be our distribution partners in this, right? And let's give them a complete product instead of asking them, hey, here is my DPC, fit it into your plan. We started giving them the whole plan, right? And that has worked now really, really well. You know, like I was sharing, we doubled in size last year. From about 3,200 members, we closed the year at 6,500 members. And a lot of that was because of, you know, simplifying health plans and partnering with brokers to distribute it.
The health insurance brokers, they go to an employer and they can sell any product, Cigna, Blue Cross Blue Shield, or First Primary Care. So now you're giving them a percent of the commission, just as you would if they had signed up an employer for Cigna, et cetera, right?
We don't give a percentage of the commission. We build in a fixed cost per employee per month for them as their role as benefit advisor.
So they're still incentivized.
Yes. So we kind of actually removing this broker, you know, nomenclature away and changing it into a benefit advisor, because now we rely on these benefit advisor to communicate alongside us on how the plan works, how the plan functions, and even after it is sold, continue to educate the employees on how to utilize the health plan better, right? So they have taken up more of an advisor role, and we moved them from a percentage model to a fixed cost model, just like we are as DPC, right? I get a fixed cost per employee per member, you get a fixed cost per employee per member, right? Now both of us, let's work to educate employees on how to use healthcare better and keep the cost low for the employer. Now you don't win and I don't win if the cost goes up, basically.
Gitu, I think this may be on topic. I saw in the pitch deck something about a bronze plan and a platinum plan. Is that part of this discussion?
I think so. So, you know, I think that was, again, one of the big sort of steps that moved us forward in this journey. Because what was happening was, if I go to a 100-employee company again, and they are already on Blue Cross Blue Shield, and if I tell them, hey, you're not going to have any PPO network, you're going to be completely in our ecosystem, everybody is scared. They don't want to leave their Blue Cross network. They see this doctor that takes their insurance, or they take this medication, So you will have a hard time going into a company and taking them away from, I call it the addiction of the PPO networks, basically. So what we did was, instead of taking those PPO networks away, we again started renting a PPO network, embedding it into our plan, and telling the employees that you can continue doing care the way you are doing. Right? Today, you pay copays, you pay deductibles, you look up your PPO network. Every time you need healthcare, you go to your network. And you can continue doing that. We're not taking anything away from you. But we're going to give you another pathway within the plan where you can get care and pay nothing. You can get $0 care for primary care, $0 care for labs, generic drugs, imaging, bundled surgeries. All your copays and deductibles will be waived. And if you do end up in a hospital, we are there guiding you. We don't want you to worry about a deductible. We will get your deductible waived. We just want you to engage with your primary care team embedded in the plan when you are utilizing healthcare, right? So we almost built these two pathways. We call it the bronze and the platinum. Bronze is the traditional way of getting care, where you pay copays, deductibles, co-insurances, and platinum is where you get DPC guided care at $0. A carrot and a stick approach to influence behavior, basically.
Yeah.
So you're not,
That's great. And I feel like if people go the other route and keep paying deductibles and experiencing out of pocket, it shouldn't take long, especially with proper education, to change that behavior.
So the other, I think, important component to understand here is that, a solid TPA partner is very important to make this happen. So TPA is, again, the person who administers our health plan, right? So again, going back to 100-employee company, let's say 50 people are using care through us. They have engaged with DPC, but rest 50 are still not. And they continue to use their PPO network for medications and imaging and going to ERs for stuff they shouldn't be going to. All those claims are going to hit our TPA. Our TPA still has to process those claims according to the network and pay those claims. Now, if I have access to those claims as a DPC doctor, if I see that, hey, you are getting this acne cream from Walgreens and they're charging $150 to our health plan every time you go, but it is actually in our free DPC formulary, I can then do an outreach to an employee and say, hey, would you like your copay waived for that, and have me shipped, right? So transparency into the claims empowers direct primary care to do outreach to the employees who probably haven't yet been educated properly on what the health plan can do for them. And if I don't have visibility into that, then I don't have full control over how my health plan is run, right?
Yeah, and go into more detail about that, because I don't think people understand why you go to the pharmacy and if you have insurance, your medicine costs more than if you don't.
Yeah.
And what you're doing within First Primary Care to pass those cost savings to the members.
So we started our own prescription program, and we do two things in that prescription program. And our prescription program is, again, embedded into our health plans. One is we have about 1,000 generic medications that are absolutely free for our members. So most, 85% of the medications that generally people need are free on our program, and those can be mailed to people's home at no cost. Mm-hmm. Because we have seen this. Take an example of Z-Pak. You can GoodRx that Z-Pak now, And you'll see the cost of that Z-Pack will vary from one pharmacy to another pharmacy by several dollars.
Right.
Right. And for some drugs, the difference is huge. People use the sildenafil Viagra example a lot, right? Like, here at Costco, we can get it for $10, 30-day supply, whereas Walgreens, it's $660.
Yeah, it's
for
crazy.
the same genetic, sildenafil, right? So when you, as a consumer of the traditional health plan, all you see is that $15 copay. You really don't care whether you go to Costco or you go to Walgreens, basically, right? You're just gonna go to whatever is around the corner. But the health plan now has to pay a whole lot of variable cost for those drug claims. And in fact, we all know that these generic drugs are dirt cheap. They can't cause cents on the dollar to basically make.
Right.
So what we do is we partner with a pharmacy company at the back end. We pay them per member to have access to their formulary. And any member we enroll with that pharmacy partner, they have access to our generic, formulary for free. Whether you are on one medication or you are on 9 medications, you get them all for free, right? So that way we eliminate all those sort of variable behaviors, people going this pharmacy, that pharmacy, and we not knowing until after the fact, when a claim hits, what is the cost of the drug, right? It's too late by then.
Right.
So that's the genetic component. But the second component, which is even more, I feel like, impactful, is sourcing high-cost drugs overseas. Lot of so our plans, fully cover biologics, biosimilars, even GLP-1s for diabetics. All that stuff is covered, right? Nothing really is excluded that way. But again, where you get those drugs can be a huge difference cost-wise. I share the Skyrizi example.
Yeah, that's where I was going next.
So Skyrizi, again, this was about 80-employee company, blue-collar company here east side of Houston, and we are in the phase of putting a proposal for them and what we can do for them, right? And we are looking at their prior year's drug claims. And there is one member who is on Skyrizi, and they are on the United Healthcare plan. And United Healthcare is paying $22,000 per injection for that Skyrizi, right? It's a quarterly injection. So we have pharmacy partners that source it internationally for about $6,800 per shot. Again, we moved this group 80 to a self-funded plan. This is our own third-party administrator. Now the claim is not going through United. The claim is going through us, and we buy it for $7,000 instead of $22,000. $15,000 saved just on that one injection, basically, times 4 a year, $60,000 a year saved. Go back to the claims fund that we were talking about that the employer controls. Huge impact to that claims fund, basically, right? In an 80-employee company, you're not going to have probably $600,000 of claims fund, and $60,000 goes a long way to protect that.
Sure, that's awesome. Do you have any technology or patents that you're using to run this?
None so far.
Just a lot of brilliant stuff and a good team, huh?
So we do have a lot of components. And I do see with time us owning some of those components as we do it, both on the tech side and on the service side.
So obviously I know you personally, but we talked about you and your background. Is it a one-man show, or do you got other members of the team that need discussing?
Oh, no, absolutely. It's never a one-man show, right? Again, my nurse practitioner partner who's been with me since day one, from our garage days to today. He's been hugely helpful in just being there. And I can ask him anything, and he's there to help. The second big addition was this is ex-military, somebody who had helped design a CRM, a customer relationship manager software. So he had helped design it, get it off the ground and commercialize it. And I met him, and I really was looking for somebody who can automate a lot of the business processes for us. Because, we were, again, a small mom and pop shop. We wanted to figure out how we automate, how we market ourselves, how people interact with our website, how do we capture leads, how do we nurture leads, how do we get people to sign up online, take them from their whole process to pairing them with a doctor, get their health intake, get their secure app downloaded, and pair them with the doctor, and they can complete a visit. So all that had to be automated because it was done manually. So he came into our company, and he's our partner now as well. He's been with us for almost 7 years, but he is our chief operating officer and has helped really automate a lot of our business processes and integrate various technologies that we use to deliver the services we deliver. And then lastly, I want to give a shout out to Dr. Vo, who is our chief medical officer. And she was the second physician I hired, basically, and straight out of residency. She was very passionate about direct primary care. She didn't want to do the traditional model, and she came up to me and said, "Hey, I want to work with you. I love the model. I don't see myself working in the old model. Can we team up?" And I was like, "You know what? Let's do it." So she's been phenomenal, and again, on the recruitment side, training side, maintaining a solid culture. And I guess I can't forget my own wife, my doctor, Lee, who is a physician as well. And it couldn't have happened without her support. She was the one. Yeah.
I love it.
Yeah. She's been the one funding this while I figured out how to do it. For the first 5 years, I had zero, paycheck, basically.
Of course.
Wow. I want to segue over to remote patient monitoring, where I think there's tremendous value there. Medicare pays for it. I do think that there's potential that's being overdone a bit. I think there's some people that are doing it very well. Since you're not really treating a Medicare population, is there a way that you integrate remote patient monitoring into your business, and how does that work?
Great question. A lot of, I feel like, the behavior and the solutions that are developed in the traditional world are driven around the reimbursement model, right? And now there is some reimbursement Medicare is doing for remote patient monitoring. A lot of people are going to be remote patiently monitored, whether that leads to any meaningful impact down the road or not. I think it is to be seen. But in our world, I think, Jeff, this is a lot more simpler, right? Like now my goal is to keep people healthy. Right? I want to develop a way where I can get your watches data, your sleep monitors data, your exercise data, all be fed into our EMRs. And it all can be tied and integrated. We can definitely bring AI into it to make us all more intelligent. And the idea then becomes to recognize patterns, to predict illnesses early, and be able to actively intervene proactively, right? And I think there is a huge scope in changing the very definition of what primary care is within our subscription model, without having to figure out how do I bill on top of this, basically, right? So I don't need to do any billing. I don't need to have any codes. I just need to figure out how to do primary care really well. And I think remote patient monitoring and leveraging the technology that is available to us, leveraging AI to help doctors do their job better. That's how we do primary care better.
Yeah,
I love it.
I love that.
Yeah. Hey, I wanted to ask you this, and who's your customer? Is it the patient? Is it the employer? Is it the physicians in your practices. Who is your customer? And then let's talk a little bit about money, okay, and total addressable market, that kind of talk.
So, there are three main customers that we have. Obviously, it starts with the patient. You got to provide a service that patients love, receiving, right? I think that is the first thing. The second customer is our doctors, right? Because if we are not solving this for our physicians, again, it doesn't work, right? We have to solve it on both the sides.
Mm-hmm.
And I say this pretty often, like we will look at some new, technology or some new product in our office that, hey, should we incorporate this or not? And generally it has to pass through the lens of, does it help our doctors keep our patients healthier?
Mm-hmm.
And are we, providing more value to our patients, and they are going to appreciate it, right?
Mm-hmm.
If it passes through those two lenses, yes, we will do it. Otherwise, we won't, right? We are very mindful of not bringing layers that make our physicians' lives harder. So physicians are very much a customer, right?
Mm-hmm.
From the standpoint of how you structure everything,
Mm-hmm.
service-wise, but also work environment-wise, like creating a work environment and a culture where they really come and enjoy, practicing at the top of their license, basically,
Mm-hmm.
right? But the third customer is our employers. I truly believe employers have the ability to fix this healthcare mess. I think if they start, and when I say employers, by the way, I mean our physician employers as well, right? In fact, those guys probably the topmost than any other employers. And what I mean by that is that our physicians should be buying our own health insurance plan, right? So those are the three customers we see: patients, our healthcare providers, and then eventually the people who pay for the healthcare, which in our world is employers, not Medicare or Medicaid, basically.
Gitu, as far as trying to grow a national footprint, how do you see that happening? Do you see potentially partnering with other DPC groups? Do you see more of an acquisition model? I mean, all of that requires capital, particularly the acquisition side of it. And as I'm saying that, I'm just thinking, I'm not real happy with what private equity has done to our healthcare system. Are you going to stay strong? And if one of these entities comes along and throws a big check out there, are you going to manage to keep physician run, physician owned?
I have to. I have to. There is no other way. That was the vision we started with, that it has to be physician led. It doesn't have to be fully physician owned, but it has to be fully physician controlled. So we're gonna keep it that way. And if we don't keep it that way, then we again become the beast that we're trying to slay, basically.
Right said.
And I'd like to think that the more we can organize as far as a physician community, PE can become physician equity, not private equity.
Oh, I love that, Jeff.
That's when we've arrived.
Yes.
Man, that is the best.
No doubt about it.
That's the best.
You're going to find people that really want to fly this flag.
Yeah.
And jump on board, because I said it in something I wrote a few days ago, but I think these companies and entities that think that they're too big to fail, there are cracks in, they might be small cracks in their foundation, but people like you're building solutions in those cracks. Mm-hmm. And a lot like the power of water, when that can start to flow through there and widen those cracks, that's when things really start to change.
It has happened in the history also, right? Like the change starts happening by us fixing the components they actually discard, right? Like most of these hospitals, large insurers, primary care has become kind of like a discarded thing, or basically just something to use to bring in people into their system, basically, right? Like to catch the people and push them upstream. And I think that's kind of where if we start fixing that while they sleep, we're gonna we're gonna be far ahead before they wake up.
And more to both of your comments, but I'm reminded of the story of David and Goliath, and remembering that there are way more of us than them.
Yes.
And maybe we're the Davids, but there are way more of us.
Yep.
And we're learning to finally collaborate where physicians have been divided for so long. We're learning to cooperate, collaborate, and understand that we can take medicine back and put it in the hands of those that it belongs in.
Yep.
You simply can't turn on a faucet and make more of us at the drop of a hat. You know, it takes, 10, 15 years if you add up all of the schooling to make a doctor. And it's just so important that we start to control this and do what's right for the patients.
That's right.
I used to say, or I still say, that there is no way I'm going to sit and accept that my kids are going to grow up in this system. They won't. We're going to leave a better system for them, and it's upon us to do that. Right. Nobody else is going to do it.
I've resolved myself to the fact that maybe, for me and Jeff Cole, we're probably stuck with the way it is, but we can at least start the change for the next generation. And we've interviewed so many people where we understand that the artificial intelligence, the technology, just the collective intelligence of physicians we're going to change this. And I'm refreshed. We started this out of a place of frustration. Jeff Cole and I did, because of like a lot of us, the state of healthcare is, it's broken. It is absolutely broken. Well, Geetu, I want to thank you for being on here. You have got, if I can summarize, you can tell me if I get this wrong, a direct primary care model, much more than a direct primary care model, but an actual true model that moves what we call healthcare today into a true healthcare model from a sick care model. It's physician-led, reducing costs to employers and patients, increasing access to care, increasing money for the providers, the physicians and the nurse practitioners that work for you, or their personal time. And it eliminates so much of the third-party costs that we see today that's driving up the cost of healthcare. Is that accurate?
It's beautifully said.
Thank you.
I'm glad it's being recorded.
Me too, Geetu. Thank you so much for joining us on the Merge Medical Podcast. This is Dr. Jeff Brown, my co-host, Dr. Jeff Cole, with Geetinder Goyal. Thanks so much, everybody. We're out.
Appreciate it.